Okay, let's go ahead and call this meeting to order. If you're able, please stand with me and join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you very much. Cheryl, let's have roll call, please.
Director Yee.
Present.
Director Stewart.
Present.
Director Wallace.
Can't hear you.
Director Wallace.
Present.
Director Eapen.
Present.
Director Nicholson.
Present.
Very good. And Cheryl, can you tell us please who else is in the room with you?
Yes, Kimberly Hartz,
Mm-hmm.
Tina Nunez, Chris Henry, Paul Kozachenko, Shri Bodu, and Cheryl Renaud.
Okay, great. Thank you. Well, welcome to the June 8th, 2022 regular meeting of the Washington Township Healthcare District Board of Directors to continue to protect the health and safety of the members of the board, district staff, and members of the public from dangers posed by the SARS-CoV-2 virus. The Brown Act allows a local agency to continue to hold its meetings remotely as opposed to being required to meet in person. Section 54953E3 of the Government Code requires that the board make certain findings every 30 days to continue meeting remotely. One such finding is that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote. The Alameda County Health Officer continues to recommend social distancing and the wearing of masks indoors. I refer the public to the Alameda County Health Care Services Public Department COVID-19 website at www.covid-19.acgov.org. I ask for a motion that the board make the finding required by section 54953E3B2 of the Government Code that, quote, state and local officials continue to impose or recommend measures to promote social distancing, end quote.
Yes, Madam President, I make the motion that the board make the finding required by section 5493E3B2 of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing, unquote.
Thank you, Director Wallace. Is there a second?
Second.
Thank you. A roll call, please, Cheryl.
Director Yee.
Aye.
Director Stewart.
Aye.
Director Wallace.
Aye.
Director Eapen.
Aye.
Director Nicholson.
Aye.
Very good. Thank you. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Moving on to communications, members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? No. Cheryl, are there any written communications?
No.
Okay, very good.
It's just me.
Oh, I'm sorry. Director Wallace, did you say?
I just said, I don't know if it's just me, but I couldn't hear anything you said.
Oh, are we doing okay on audio? Everybody else? You're good? Oh, I see lots of thumbs up.
Yes, I'm hearing well.
Okay. I don't know what the issue is you're having.
Okay, well,
You can log out and
must be,
try to come back in maybe?
I know. Yes, yes.
Okay. All right, we'll move on. Oh, well, let's see. See if he comes back. I don't want to move on to the consent calendar until he returns. I wonder if he's having trouble getting in now.
He's logged in, but he has not turned on his video or audio.
Let's see.
Oh. He's
So
doing,
Director Wallace, can you hear us? If you can, just maybe say something. There
There we
okay.
go.
Yeah, I got back in. Okay.
Okay,
Thank you.
great.
Thank you so much. All right, we'll move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? No? Okay. Does any member of the public want to remove an agenda item from the consent calendar? All right, hearing none, may I have a motion to approve the consent calendar items A through C, please?
Yes, Madam President, in accordance with district law, policies, and procedures, I move that the Board of Directors approve the consent calendar items A through C.
All right, is there a second?
second,
Thank you, Dr. Stewart. Okay, roll call vote, please.
Director Yee,
Aye.
Director Stewart,
aye.
Director Wallace,
Aye.
Director Eapen,
Aye.
Director Nicholson.
Aye.
Very good. Thank you so much. Now we will move on to presentations. Kimberly, I'll have you do the introductions, please.
All right, thank you, Madam President. It's my pleasure this evening to introduce Dr. Jack Rose. He is going to be presenting the overview of the stroke program for calendar year 2021. And let's give you a little bit of an overview of Dr. Rose. He joined Washington Township Medical Foundation in early 2014. Dr. Rose received his undergraduate degree from Stanford University and his medical degree from Columbia University's College of Physicians and Surgeons. Dr. Rose received his medical and neurological training at New York Presbyterian Hospital's Neurological Institute, where he was selected as chief resident. He did a 2-year neurocritical care and stroke fellowship at the University of California, San Francisco. Dr. Rose is an expert in neurointensive care and cerebral vascular disease and was among the first 100 physicians in the world to become board certified in neurocritical care. He is also board certified in neurology as well as vascular neurology. Dr. Rose's experience and leadership augments Washington Hospital's comprehensive stroke and neurosurgical programs, especially in cerebral vascular neurosurgery and interventional neuroradiology. He personally provides the patients treated at Washington Hospital with the continuity of care that is critical when treating the full range of cerebral vascular conditions. Dr. Rose is co-medical director of the stroke program with Dr. Khalsa. He is also chair of Washington Hospital's Continuing Medical Education Committee and its Institutional Review Board. So welcome, Dr. Rose.
Thank you very much, Kimberly, and to the board for again inviting me to present and praise the work of our stroke program. I'm going to share my screen. Can you guys see my screen now?
Dr. Rose, your screen is only quarter of it. We can see it. Do you mind exiting and sharing it again?
Sure.
Just, yeah.
Oops.
Dr. Rose, you can go to bottom right corner before the.
This?
Yeah, there you go. Yeah.
Okay,
try
can you,
that.
is that better?
Yes. All right.
Okay.
Sounds good.
All right. Sorry for the technical difficulties. But again, thanks for allowing me to present our report of our 2021 calendar year for our stroke program. And I present this on behalf of our entire stroke program team, including my co-medical director, Dr. Khalsa, and Maria Nunes, our clinical manager of the stroke program, who are guests with me this evening on for this meeting. Many of you have seen this similar presentation in the last several years, and not much has changed, but I do have some excellent new information to share with you. So I'll go fairly quickly through the structural parts of the talk. We have a very strong stroke program leadership that I get to work with, including Larry Labossiere, the VP CNO, who's done a great job taking over Stephanie's role. I've already mentioned that Dr. Khalsa and I are the co-medical directors of the stroke program, but we're blessed to have two additional neurologists involved, Dr. Sharon Singh and Dr. Ravi Kalan, and Dr. Khalsa and I are both board certified neurointensivists, in addition to neurologists. And we have strong input from from nursing leadership, including Brenda Brennan and Michael Platzbecker, who work closely with us and help oversee much of the brunt work of our program, which is done by our outstanding stroke program clinical manager, Maria Nunes, who is also a nurse practitioner, who I have the benefit to round with on a daily basis. You probably are well aware we have a very unique program structure here at Washington Hospital. We're one of the few hospitals in the country, if not the world, that have 24-hour, 365 dedicated stroke nurses who can see patients with suspected stroke or stroke at all times in our ER, anywhere in our hospital. And many of our stroke nurses have advanced training and certifications in neuroscience or stroke. Like I said, we have 4 neurologists involved in the program. We have multiple neurosurgeons, as well as one vascular neurosurgeon, Dr. Thomas. And we have a colleague, Dr. Carrington, who is an interventional radiologist who does neuro procedures in the neurocath lab, like Dr. Thomas does. We have a very patient-centered stroke care approach, just like the patient-first ethic for Washington Hospital. And it is truly multidisciplinary. We have involvement very early on from EMS, our 911 providers, ER, physicians, staff, nursing. The dedicated stroke nurses, like I mentioned, are very present from the very beginning of when a stroke patient hits our hospital. Pharmacists are involved early on. The neurologist, obviously, either inpatient or over video. After hours, we have the capabilities to remotely televideo in and see a patient at a moment's notice together with our stroke nurses, which is really been extra helpful during COVID. We have radiologists that read our picture tests very, very quickly in a timely fashion, and we can involve our interventional radiology and neurocath lab anytime. We have a strong ICU presence, and our stroke patients are well taken care of in the ICU or any part of the hospital. We have dedicated areas in the regular part of the hospital to take care of stroke patients as well. And we have outstanding rehab and therapists, physical therapy, occupational therapy, speech therapy, as well as experienced case managers and social workers that can help us with our dispositions. And we are very proud of our collaborative multidisciplinary approach. And we feel that our patients benefit very much from all these disciplines being involved. And this isn't just something that's possible for our stroke patients. All of our stroke patients get pretty much all of these providers and allied health staff involvement. We also focus on very, very high quality care and fast, efficient stroke care. One of the biggest things that we've been working on for the last several years is to speed up the delivery of an accurate delivery of the one stroke treatment we have for acute blocked artery strokes, and that's TPA. And one of the ways that we've been trying to speed up our treatment times, because the faster you can identify a blocked artery stroke and get the possible IV treatment, the higher the odds of having a good functional outcome. And since 2016, we started the Code Neuro process. So it's an overhead paging system where any patient with a suspected stroke, actually nowadays it's less than 24 hours since symptom onset or since last seen normal. There's an overhead paging system that alerts the hospital and our whole team to rapidly evaluate them, get them the tests that they need, and make clinical decisions rapidly, especially trying to get them this clot busting medicine if they qualify for it. And since 2016, that stroke Code Neuro process has really helped us speed up the care of our stroke patients. And then how do we disseminate the data about our stroke program and do quality improvement measures? Well, we have a stroke review committee that is also multidisciplinary. It's monthly, and we review all of our interesting stroke cases, our stroke volume, our mortalities, length of stay, any issues in terms of quality improvement. And that's a monthly committee that has multiple partners, including people from emergency medicine, hospital medicine, radiology, nursing, etc. I also am involved in the critical care committee to go over ICU related issues. And as needed, we have vascular surgery or neurosurgery review committees. We also annually present to the Qip Quality Steering Committee, which I did last month, and annually present to the board of the directors. That's the presentation right now. How has our stroke patient volume been this past year compared to past years? Well, you can see here that chart towards the right is showing that our stroke volume for 2021 was 467, which is right similar number that we've had for the last 5 or so years. And interestingly, there was only a very small decrease in volume early in 2020 during the beginning of the pandemic. We did see a very transient decrease in the numbers of patients showing up timely in a timely manner during the beginning of the pandemic, but we worked hard to educate the public and make sure that stroke was not one of the things that they delayed their care for despite the pandemic, and that our hospital was a safe place to be, and it was vital to come to the hospital for any suspected stroke. So our numbers have been pretty stable over the last several years, about between 450 and 500 stroke cases per year. And of that, about 80% of these patients are blocked artery strokes or warning signs of blocked artery strokes, and about 20% of them are bleeding strokes. In terms of neurointerventional and vascular neurosurgical procedures, our volume over the last 5 years are in this chart in front of you. We've had about 7 thrombectomies, which is a treatment for large blocked artery strokes done in the neurocath lab. Similar to years past, we're hoping to increase that volume over the next few years as well. Boiling and clipping are neurosurgical procedures performed to treat broken, ruptured, or unruptured brain aneurysms. This is a particular area of interest of Dr. Thomas and mine, and we increased our volume in 2021 from the last few years to 16 cases, which is a pretty high volume, especially for a relatively small community hospital such as ours. Carotid stents, a procedure to open up a narrowed neck artery that is causing neurological symptoms or is at risk for causing neurological symptoms. That procedure has been less popular based on new clinical data, suggesting that most patients that have narrowed neck arteries can best be treated with medicines, or if they're having brain symptoms or mild strokes, it's better to have them have a typical vascular carotid endarterectomy as opposed to stenting. But there are some occasions when stenting is still indicated, and so we did 3 cases of those in 2021. How about our outcomes? Well, these are the 10 key measures from Get With The Guidelines, which is a program from the American Stroke Association, and these are 10 high-quality performance measures that we track on an ongoing basis, as well as quarterly and yearly. These are the 10 key quality measures for the calendar year 2021, and they range from such measures as making sure patients get education about stroke, whether we give TPA appropriately, to the percentage of eligible patients, whether we do things to prevent blood clots from developing in the legs or the lungs, whether we give them blood thinners at discharge, whether we give particular patients with heart arrhythmias particular type of blood thinners, whether we talk about smoking cessation, prescribe a particular cholesterol medicine called a statin at discharge, assess them for rehab, screen them for swallowing trouble, and use validated stroke severity score measures within 6 hours of onset. And you can see here, our goal is to be above 85% for all of these measures, and we meet that goal for all of these key measures. And in fact, many of these measures are at 100% for the whole year, with only a couple being less than 100%. So we even though our goal is 85%, our additional internal goal is to get really these up to 100% as much as we can. In terms of how well our patients are doing at the time of discharge, in terms of their physical functionality and disability related to their stroke, well, if we measure a functional outcome at discharge and you dichotomize it to either a good functional ability or a poor functional outcome at discharge, so that's typically about 1 week for our blocked artery stroke patients, a little bit longer for our bleeding stroke patients. And you compare us to how the functional outcomes are at other California hospitals. At discharge, more than half of our patients already have a good functional outcome, 62% in the calendar year 2021 versus 27% in other California hospitals. So we stack up better in terms of functional outcome at discharge, and that's been a consistent finding for us over the years. But we don't rest on our laurels, and we have many performance improvement projects that we work on. Like I mentioned, we have had a strong push towards trying to get TPA, the clot busting medicine that can help blocked artery stroke patients, to get it as quickly as possible to eligible patients. And that's patients that show up within 4.5 hours of symptom onset. And if you look at how well we do giving that drug within 1 hour of hitting our door in our ER, for the last several years, we've done a very good job of exceeding an 85% goal of doing it within 60 minutes. And last year in 2021, we were 92%, which is great. You'll notice that in the many years past, we were below this goal, but we've worked hard to get it above that goal and to keep it there. However, a lot of the stroke organizations, including the American Stroke Association, American Heart Association, are pushing the envelope further and trying to get centers of excellence for stroke to get TPA even faster than that. And but if you compare us in terms of the 60-minute time window, this is looking over the last 3 years, how do we do in terms of getting TPA within an hour compared to other certified primary stroke centers like ours? We're the percentage in green, where the Washington is in green. Our orange is the other primary stroke centers. We do a better job over the last 3 years than other primary stroke centers. But we want to even push that treatment time further down if we can do it appropriately and safely. And so the new latest goals have been to try to get a high percentage of patients treated within 45 minutes. This was especially challenging during the pandemic, and you can see that we're not quite at the newly established goal of 75% of our patients receiving TPA within 45 minutes. We're around 50 to 60%. But we've made some changes, and we're improving that outcome for now. And in fact, there's push towards getting this treatment time down to 30 minutes in about half of the patients as well, which is a very rigorous goal to try to achieve. And we've done a great job of always getting it less than 60 minutes for the most part, and now mostly less than 45 minutes. So we figured we needed to make some changes to try to certainly get us anywhere near the 50% less than 30 minutes. So we thought and worked carefully with our pharmacy group about how we might speed up our drug treatment times. And one of the things we realized was that there are relatively new guidelines that suggested that stroke centers could use a different formulation of TPA. It is TPA still, but it's a different formulation of TPA. So as opposed to the typical drug that is called Alteplase, there's a new drug that was that was modified to be a safer and more effective TPA. It's called Tenecteplase, or TNKase for short. That's been used in the past for MI and pulmonary embolism, just like alteplase was previously used in MIs. And it's been studied as an alternative TPA for stroke patients. And new data has come out suggesting that it is just as effective, if not potentially more effective in certain severe stroke patients, and just as safe. And the nice thing about this new version of TPA is that it can be kept in the emergency department as opposed to the pharmacy. And it's a quick bolus of a medicine as opposed to an hour infusion. And so we thought that this might be an excellent way for us to improve our treatment times. And so we developed a performance improvement plan to switch our TPA formulation from alteplase to TNKase with the input of pharmacy, nursing program, and to the ED staff. And we created education modules. We trained all of our stroke nurses about how to do this, and all our pharmacists are well trained to do this. And this went live a couple of months ago. We switched from alteplase to TNKase. It also happens to be a cost-saving measure. It is slightly cheaper than the alteplase. And so far, we've had excellent results. So far, if you look at our average TPA time from, say, February this year, our average was just under 60 minutes, for example, in the month of February. But after we made the switch in April, our average treatment time has gone down to 40 minutes. So we're happy with that. Here are just a couple of examples. One, the first time we gave it was in mid-April, and we were able to do it in 34 minutes. 2 days later in 48 minutes with good clinical results. And the latest case that we had earlier this week, we were able to give it in 24 minutes, which is extremely fast, again, with good clinical results. So we're seeing very good results with this adjustment to our TPA protocol. And we will continue to monitor this in our stroke review committee. We continue to do a good job, similar to other hospitals, stroke centers, in terms of getting our picture tests of the brain read quickly and documented and communicated on time, as well as our ER physicians seeing the patients quickly compared to other hospitals. And we do a better job than other certified hospitals at getting a rapid blood glucose level measurement. If patients have very, very high blood glucose levels at presentation, their chance of having a bad outcome is higher, and it's riskier to give them TPA, it turns out. One of the things that we're also working on is we're trying to, again, educate the patient, the community and the public that despite the pandemic, we still really want patients to arrive to the hospital for any suspected stroke or warning sign of a stroke via ambulance, not be driven by a family member, not to drive themselves. And this is a chart showing you that over the last 4 years, whereas between 2018 and 2019, we saw an improvement in the percentage of our patients showing up via EMS. That dropped down over the last couple of years down to about 50% of our patients showing up by EMS rather than walking in some form. So we're still working on measures to try to educate the public so that they do use EMS activation and not try to get to the hospital via other means. We have performance improvement around this and are trying to attack this by different measures. And mostly that's community outreach, community messaging, and we have advertisements on ambulances explaining why it's important to be fast about recognizing a stroke and calling 911. Another performance improvement we've been working on is discharging appropriate patients on a cholesterol medicine called a statin, but not just a statin, an intensive dose of a particular statin. It's called intensive statin therapy, and only 2 of the statins that we use at a particular dosage qualify for this. But unless patients are of a particularly advanced age or have other factors, it is strongly recommended that patients be discharged on an intensive statin. And so initially in 2019, when that new recommendation came out, we were only about 60% compliant with that intensive statin therapy, but we did a performance improvement project, and we've, the last 2 years, been able to get that to the high 90%. And that has included education of our hospitalists and pharmacists, as well as we have a best practice advisory through EPIC that pops up on hospital discharge for anyone that is being discharged with a stroke or TIA, alerting the physician that they should be discharged on a statin, and if not, for them to document the reason why. So we're proud to see that improvement in terms of the intensive statin therapy. This is just an example of what that PI plan looks like for intensive statins. In terms of patient satisfaction, we also want to get feedback from our patients about how their experience at Washington Hospital is and post-hospitalization follow-up. And in order to get high quality follow-up data, we engaged with a company called MedTel, which is a third-party data collection service that exclusively works with stroke patients, and following up on how patients are doing, especially short-term and long-term. 7 days and 90 days is a requirement for advanced levels of stroke certification. So it serves a couple of purposes for our program. And some of the things that we ask patients after their discharge at a week after and 3 months after is, how well they're doing functionally by asking them ability questions, whether they followed up or have an appointment with their primary care doctor, whether they're taking their medicines as prescribed, whether they know what their stroke risk factors are, and can they identify warning signs of a stroke. All this is done through telephone follow-up calls. And actually, the yield from this company is outstanding. I mean, we get on a monthly basis a very high yield response from our patients. It's in the 90% of our patients respond to this company. They're very good. And one of the things we did notice was that in 7 days, a high percentage of our patients were not necessarily following up with their primary care doctor or had a follow-up appointment made. And so we decided to use this opportunity to create a detailed discharge flyer that, among other things, included the importance of following up with their doctors in a timely fashion. And this is part of a performance improvement about outpatient follow-up to try to improve compliance with follow-up doctor's appointments. And what you notice here is that in September of 2021, our patients in 7 days reported about 50% of the time that they followed up or have an appointment with their primary care physician, which we wanted to improve. And by March 22, you can see that our responses in that same time frame has been about 70%. So we think that our performance improvement plan has worked, but we're tracking this on a monthly basis. In terms of educating our staff about our program and to improve our quality care, to identify any problems, we do have education for the doctors and nurses and anyone interested in our stroke patients. I do a monthly, it's not bi-monthly anymore, but it's a monthly presentation going over 3 interesting stroke cases. In fact, I gave one earlier this afternoon, and it's continued via Zoom the whole time despite the pandemic after a short break. And it's a very well attended conference, and both CME and CEU credit are available for physicians and nurses. And it's, anyone from the hospital is invited and welcome to join. We also have the monthly stroke review committee that can have educational items. And in the past, I've given grand rounds. We have critical care skills day that includes neuro presentations. Our stroke nurses do ER or nurse huddles on a frequent basis, and we do code neuro simulations, especially for our newly hired stroke nurses, which works really well to improve the speed and quality and consistency of our stroke care in the emergency department. We also don't just educate our staff, we educate our patients and their families about stroke care. We give them individualized information about why they had a stroke, how to ongoing prevent additional stroke from happening, and recognize signs of recurrence in themselves and in their family members and friends. And we focus on rehab education as well, diabetes, pharmacy education, make sure they understand what drugs are prescribed and why and how to take them, and what risks or side effects there may be, and individualize the plan for every patient. And we also track our how well we do on that. And in terms of community education, we continue to work closely with our local EMS. We attend quarterly meetings that are now held via Zoom, and we do submit data to our EMS and to make sure that we're meeting the requirements of them. And we've in the past given talks to the EMS providers about stroke care advances. We do have a stroke support group that stopped meeting during the pandemic, but has since resumed via Zoom, which was a little bit of a challenge because many of our stroke survivors may not be so technologically advanced, but we worked with them to be able to do that. And it's still it's become a well-attended stroke support group. We do other community outreach education events, although some of those have been postponed because of COVID, but we're working on trying to get back to those as needed. And once we can have in-person events, we'll do that safely. Because of the pandemic, we've also moved some of our community education online. Maria Nunes and I gave a Facebook Live presentation on signs, symptoms, and stroke prevention, for example, a few months ago, and we continue to do occasional stroke awareness pieces in the Tri-City newspaper. In terms of achievements in the last year, we did receive the Get With the Guidelines Gold Plus Elite Award and Target Honor Roll for diabetes. We were recertified by the Joint Commission for Primary Stroke Center. We added Dr. Carrington a couple years ago to increase our neuro IR coverage, which is near 365 24/7 now, and are increasing our thrombectomy cases. We've also expanded our outreach to outside hospital stroke patients, especially brain hemorrhage patients, together with Dr. Thomas and my practice. And we have other marketing strategies in place and being enrolled for our neuroscience program. In terms of our program goals for the next year, like I mentioned, we're working on improving our door-to-needle time for TPA to get more than 75% of the time within 45 minutes and up to 50% of the time within 30 minutes if we can do that safely. And we think with our TPA adjustment to use TNKs, we'll be able to get there. And we continue to use expanded time window and a new stroke software that we instituted a few years ago to identify which patients have blockages of large arteries that might qualify and benefit from catheter-based procedures, not just drugs. And our goals also include in the future to advance to the next level of stroke center certification, which is thrombectomy capable. It's not that we don't do thrombectomies here, but we're not officially certified as a thrombectomy capable center yet, but we're working towards that, as well as an even longer term goal to obtain certification by the Joint Commission as a comprehensive stroke care center. And so that's the presentation. And again, just to reiterate for everybody on the call, to everyone and their family members should know how to recognize a stroke. You can use this Be Fast mnemonic. Any sudden problem with balance, sudden problem with your eyes, sudden problem with a drooping face or slurred speech or weak arm is a potential sign of a stroke, and you want to act quickly to call 911 and get to the hospital so that we can take care of you. So I'd be happy to answer any questions that anyone has. So that's the presentation.
Questions? Well, thank you very much, Dr. Rose. Very exciting what's going on, the wonderful changes, and how hard everybody's working. Thank you.
Thank you very much.
All right, then we will move on and move on to reports. Dr. Hyder, you're up next. Chief of Medical Staff. Is he there?
Thank you. Good evening
Oh, there
to
you are.
all.
Good. Hello. Good evening.
Good evening to all. Thank you so much. So first of all, the Washington Hospital active staff members are 341 with allied health 35, ambulatory 92, consulting 8, courtesy 26, provisional is 68, leave of absence is 2, and the total number is 572. And the other thing is, as we all know, that the COVID cases are increasing. Even in the hospital, we have some 25 cases, something like that. And but most of them are not that sick. And in the community also, you could hear a lot of friends in the families and all that. There are a lot of cases, but they are not, have to go to the hospital or anything. They are taking care of them in the home, most of it. And so we have to be very careful. Mask and all that goes without saying. And now they're recommending Alameda County even to put mask at home also. So this will continue, I think so. And the other thing is today evening we have a a leadership conference with the intention to solve all the doubts and other things regarding the overview and rationale for changes in the bylaws and organizational manual. And it went well. There were a lot of questions were there. And the attendance was not great, but we have given them chance to look into it and to come back. And it's still the general medical staff meeting will be in person on 14th of June. And we hope everybody attend and they can come and vote. And that is the reason to have this today meeting we did, so that if they have any questions, they can ask and resolve it, so that it will be easier for them. They can come that day, vote, and pick up the boxes, and if they don't want to stay, they can go. So that was the whole intention. We try to, explore if there is possible to do on Zoom, but it's not that we are abandoning Zoom, but it will be in the future. But for the voting purpose, probably it will be better with this. So we have all decided to do this, and hopefully we expect it to go good. This is my report.
Okay, very good. Thank you, Dr. Hyder. Moving on to our service league report, Debbie Fury.
Hi, good evening, District Board. How are you?
Good.
And greetings from the volunteers. May was another busy month for the volunteers. During the month, we had 104 volunteers contribute 1,299 hours. On a variety of assignments, including NUA, the gift shop, telemetry, Morris Hyman. In May, the Service League hosted 3 orientations, from which we were able to recruit 5 new adult volunteers, yay, and 25 college. So hopefully they come back, go to school and come back. We also were happy to announce that we are finally welcoming back our high school volunteers. 11 volunteers are being trained this week for the lobby. And so you'll see their smiling faces in the main hospital in the lobby, and we're excited. They're also in the gift shop, and we're hoping to open up the gift shop to 2 shifts. So the afternoon and the evening, so that it will be available to more of the staff that work the evening shifts, because we'll have our high schoolers and they want to put in their hours. We also have that we opened up the ED for the NUAs. So we're assisting the nurses and staff in the ED with folding the gurney sheets, stocking empty rooms, answering call lights for the nurses. And the difference with the ED and the nursing unit, which is on the floors, is that in the ED, everybody comes in suspected COVID. They're all stopped. So we can't go in the rooms until they're cleared. And once they're cleared with no COVID, we go in and help that way. So it's exciting to go back. And yes, I've trained, so I'm very excited about that. And we were so welcomed in the ED. It was wonderful. We love the staff. They are just so happy that we're back. And so we're real happy, and it really touches my heart. And that's my report for the month.
Great. Thank you so
Any
much.
questions?
Oh, it'll be nice to see more of those maroon shirts in the main hospital lobby. And yeah, good. Glad that they can come back. Thank you.
Thank you.
All right, and next is our Lien Report. I'll have Kimberly, please do the introductions for Dr. Kirkton.
All right, thank you. I'd like to introduce the 2 speakers this evening. The first person to be introduced is Dr. Bettina Kirkjohn. She has been with Washington Hospital since 2001. She did her undergraduate work at Stanford University, medical school at UC Irvine, and went on to do her OB/GYN residency at Kaiser in Oakland. She joined Washington Township Medical Foundation in 2011 from private practice. She started in the Kaizen Promotion Office in 2016, and beginning July 1, she will be the new Physician Chief of Quality for Washington Township Medical Foundation.
Wow.
Yes. The other person that it's my pleasure to introduce is Sabrina Valade. She joined Washington Hospital in 2017 and now serves as the Director of Strategic Planning, where she oversees the Quality Incentive Pool known as Qip program. Prior to 2017, Ms. Valade served as the Health Center Manager for Stanford Healthcare, where she oversaw operations of an innovative employer-based primary care clinic. Prior to her role at Stanford, she served for more than 17 years at Santa Clara Valley Medical Center in San Jose, California, where she held various roles during her tenure, all focused on improving access and care for patients. Ms. Valade received her master's degree in public health and her BS in health science from San Jose State University. And it's my pleasure that they're going to be talking this evening about the Whitman Quality Alignment.
Good evening. Can you see my screen?
Yes, we can.
Okay, terrific. So good evening. It's our pleasure to share with you tonight efforts that have taken place over the last year to align multiple quality improvement efforts at Washington Township Medical Foundation and our efforts to integrate those within our Lien infrastructure. And so first, I'd like to provide just a brief overview of Whitman and the services offered. So Whitman has a large presence within our community, providing over 180,000 patient visits per year at 20 clinic locations by over 100 physicians and advanced practice providers. Whitman provides a wide range of comprehensive care, including primary and specialty care services. They partner closely with Washington Hospital, which provides inpatient critical care, surgical, orthopedic, obstetric care, and many other types of care. Whitman's patients utilize Washington Hospital's ancillary services, such as lab, radiology, and physical therapy. And of course, Whitman is continuing to run a COVID testing and vaccine program for our community. And so external challenges. One of the challenges faced by healthcare delivering systems is that quality is influenced and measured by multiple organizations, governmental organizations, regulatory organizations, and insurance payers. And those different groups focus on different quality measures. They focus on different populations, and at times they even have different standards for the same quality measure. And this results in multiple dashboards, multiple reports, and interventions as clinics strive to meet those expectations. Over time, increasingly, payment is also tied to quality, making it more critical that we as a healthcare system achieve those varying standards. And while I think the efforts by these different organizations are well intended, having a ever-moving kaleidoscope of quality goals and standards set by multiple programs makes it complicated to clearly see and drive overall quality for patients. Internal challenges. So generally speaking, Whitman is performing well in quality, and it's important to acknowledge the efforts of staff and clinicians that have achieved this over the years. One of the challenges, however, is that Whitman has a wide diversity of services and multiple physical locations, and that's resulted in quality improvement activities being more siloed than we would like, with efforts maybe focusing on a particular site, a particular measure, or a particular population. Often also solutions were developed at the local level, but not always spread to the broader organization. And so overall, the results are good, but the approach is difficult to sustain, and it doesn't allow the benefit of efficiency and system-wide improvement that we'd like to see. The last factor in this movement towards aligning quality work for Whitman is the creation of the Quality Incentive Pool by the Department of Healthcare Services in California. So QIP, or Quality Incentive Pool, is a pay-for-performance program that's goal is to improve quality for Medi-Cal patients. It is a $100 million annual investment in district hospitals. And this financial investment allows hospitals to take the time to build a quality infrastructure to drive improvement for all patients. Washington Hospital elected to participate in 20 measures, the greatest number possible, in order to maximize this opportunity. And our executive leadership's commitment to this program, including adding key resources and technology, has allowed the Whitman quality team to focus on developing a more comprehensive approach to quality. So given all of those background factors, what is our goal? Our goal is to implement a comprehensive quality improvement program that would drive quality at the system level rather than at the individual clinic level or based on individual measures, and to align as possible all of the various pay-for-performance quality improvement measures and incentives into a single framework to promote synergy and efficiency with the goal of improving care for all of our patients. We also really saw this as an opportunity to leverage our expertise in Lien, to move beyond thinking of Lien as just process improvement work and to really embed it into daily operations to monitor and drive quality. So the Lien principles we are embedding in our work are that patients define value for us, that our improvement work should always be data-driven, that the people who do the work are the experts, they know what the challenges are and they know what the solution should be. We should focus on standardization, elimination of waste, and keep in mind that this process will be continuous learning and refinement. It's not a create a solution and then we're done. We need to continuously look at this. And so our key steps as we move through this process of developing a comprehensive quality improvement strategy are first, creating alignment and establishment of system-wide best practices and standards. So looking at all of those varying quality standards and deciding what is the one Whitman standard we're going to follow for breast cancer screening, for example. Also to develop infrastructure to support the QI efforts, which includes data collection and reporting so we can see how we're trending and whether or not our work is making a difference, and the establishment of work groups to drive solutions. So that's where we bring the experts, the clinical experts into the room and help us identify what are the challenges, what are the solutions, and how do we implement that system-wide across all clinics. And the last piece, the utilization of the Washington Daily Management System. This is really the glue that supports the implementation of all the other focus areas. And so now that I've shared some background, our overarching goal and our key steps, I'm now going to turn the next few slides over to Dr. Kirkjohn, and she's going to walk us through each of these steps and the work that's underway in them.
Great, thanks, Sabrina. So can everyone hear me? Yep. Okay, great. So as Sabrina mentioned, different groups are looking at quality and looking at different quality in different ways. So as she said, we really wanted to start right at the top with what does that alignment look like? And when we thought about alignment, not only were we thinking about alignment around those measures and what might be the best standard for Whitman, but also alignment with all the stakeholders, right? So we started by establishing our Qip Task Force, and this was really about getting the right voices in the room to really do this, this deep look. We looked at our different dashboards. We asked our experts to review the different measures, different recommendations. And we really wanted to keep in mind those key principles that patients define value and standardization. So really asking that question, what do patients think is valuable around quality for them? Next slide. And so this was quite a bit of work for our team. We did this deep dive on a number of measures. Here are 20 of the quality measures that we looked at. And we established a Whitman standard for each of these quality measures. So not an insignificant amount of work for this team to really take that look. Next slide. So here's an example of what it looked like for one of our measures for breast cancer screening. So as you can see, there are lots of different societies, specialty organizations, groups that have an opinion about breast cancer screening. And they all have an opinion about when to start and what the frequency is. So we really had multiple levels of review and discussion, not only our Whitman quality, our content experts, but then also we reached out to our breast health committee at the hospital and asked them, what they thought. And the Qip Task Force reviewed all of those recommendations and discussions. And we ended on, we decided on our Whitman standard, which was to begin screening at age 40. And we really felt that this expressed the kind of quality that we wanted to encourage our patients to have, and we wanted to provide. And the other thing that we did, we didn't just sort of establish the standard and then say, okay, ready, set, go. We did some education for our provider group, not only on the breast cancer screening recommendation, but all those other recommendations, talking about how we came to that, that recommendation so that our providers can then be partners with our patients and really have that shared decision-making around what's best for the individual patient. Next slide, please. So another strategy that we felt was really important to focus on, as Sabrina said, is infrastructure. So infrastructure is not glamorous. You know, I'm not a gardener. My gardening strategy is benign neglect, but I'm sure many of you guys are gardeners. And so, you know, those, you know, nice juicy tomatoes just don't, you know, spring off the vine, right? You need the good soil, you need the water, you need the you know, the good environment. So that's kind of how we thought about infrastructure. We knew that we needed to build this infrastructure that would really be the basis for a lot of these quality improvement projects we wanted to attack. So the infrastructure build is really designed around being able to quickly identify what services patients need and easily get them those services. And then also to develop tools to understand how is our quality improvement work proceeding, and are we successful with the improvements we're trying to put in place. Next slide. So here's some examples of some infrastructure projects that we're working on. And I really want to call out our IS colleagues, you know, our info systems colleagues. These folks are working really, really hard for us and being incredible partners to really understand what we need and to build it for us. We've developed, we call it our one-stop shopping tool, which is a way to easily identify which of our patients have a service that they need, and to really quickly and easily place the order. So we can do it from just one screen on our dashboard instead of having to hop around to lots of screens in Epic. We're also working on expanding our health maintenance tool. This is a tool that's already in place in Epic, which is quite a powerful tool that we haven't really leveraged well. And so and this is a way for not only patients to understand what they're due for example, I'm due for my flu vaccine or that kind of thing, but also for providers to be able to see really quickly what a patient is due for so that they can act on that. And so not only are we expanding this tool, but we're also engaging the clinic staff to develop workflows to most efficiently use this tool. Next slide. And then lastly, really exciting for us that we're working really hard to complete is this comprehensive dashboard. And this is a way for us to move away from those targeted dashboards and reports that we do for our different payers, but to come and say, okay, let's look at all these measures for all of our Whitman patients. And not only is this going to give us that bird's eye view of how we're doing at the clinic level, but then it's going to be able to also drill down to not only the clinic and physician level, but then also down to the individual patient level. And this is going to be a really important tool for us, again, to see how we're performing and how our quality measures are working. Next slide. So two pillars of Lien are the people who do the work are the experts. And as you know, Sabrina mentioned, this idea of continuous learning and refinement. So one of the key strategies that we're implementing is this idea of working groups. So we really wanted a strategy that reflected those Lien principles. So our working groups are bringing the right people into the room, focusing on the topics that are important to the clinics and to the leadership. And then these working groups will think about the problem, design interventions, test the solutions, at the in one or two clinics, and then roll their solutions out to Whitman once they've vetted that this is really the right solution for that problem. And those of you who have been hearing about Lien will recognize this as PDCA, Plan, Do, Check, Act. Next slide, please. So here's an example of one of our working groups. We established our colon cancer screening working group to look at our colon cancer screening, of course. And what we realized when we drilled down into this measure was that we were doing a good job of ordering colon cancer screening for our patients. Our primary care docs were really on top of that. But our challenge was around this idea of closing the loop. So did the patient actually have the colon cancer screening? And then if they did, what is the result of that drives their next screening recommendation? And we weren't really capturing that information that well. So we developed a workflow that would help us really capture this information well. We tested it with our two of our primary care docs and with our GI team and those clinic staff, and got a lot of success around that, and are starting to roll that out across our primary care clinics. And just as a little note aside, I was in the clinic last week, and one of these popped up for a patient I was seeing, and I was so excited to see that. And I talked to my MA, and she told me, oh yeah, they came over, they trained me, it's super easy, and I tried it, and it was successful. So that was a real win for me personally to see that workflow being implemented in my own clinic. Next slide, please. So last thing I want to touch on is daily management. And I know we've been talking about this in our Lien reports for the last year. This has been a big initiative for us in the Lien office. And what this is, as you know, is this is our central way that we are leading in our organization. Daily management is this system of both visibility boards and huddles. And it's really as Sabrina said, it's really the glue that kind of holds this together. We have two, just for kind of background, we have two visibility boards that we use in our clinics and in our organization. One is our frontline board. You see that on the right side of the screen. This is used by frontline staff and the local management. And it's, I like to think of it as this sort of pre-flight checklist. This is how our staff understand that they're ready for the day. They have everything they need to be successful for that day. And if not, then they have an action plan to take care of that. The other thing about this board that's really important is it engages the frontline staff in problem solving. So they're able to identify problems and also identify solutions. The other board is our process owner board, or our leadership board. And this has our organizational initiatives as well as the local projects for improvement. And this system really has helped us to understand what how we're performing, share that with the staff, and get everybody involved in problem solving. And that's one reason why we're really excited about the dashboard. The dashboard's going to be really integral to this system to really show us what's happening in quality. Our clinic managers have multiple initiatives that they're working on through this daily management visibility board system. And of course, quality is really front and center of those. Next slide, please. Of course, Whitman goals are developed at the leadership level, and then these clinic goals cascade down to specific focus areas. Leadership goals cascade down to specific goals at the clinic level, and then this is what drives local process improvement. And one of the things that I love about this system is that it's not only about the boards and the visibility around this, but it's really about the huddles. So senior leadership, myself as KPO director, our quality team led by Art Gomez, who's really been an incredible partner in this also. We round regularly, every week or every other week, where we talk about how we're progressing along these quality improvement goals. What's the status of the projects and the metrics? But then really importantly, it's a way for the clinic staff to share their barriers, what's getting in the way of them actually making that improvement, so that the leadership can address that. The quality team can deploy resources to really help them get rid of those barriers. And so this has been a really exciting partnership to just kind of pull all of this work together and give visibility around it. Next slide. And so I'm going to turn it back over to Sabrina to talk about some of our outcomes.
Great, thank you, Dr. Kirkjohn. So like Dr. Kirkjohn shared, while we're in the process of developing this system-wide approach to quality, and I agree fully with her, this is really a partnership. The Lien Office has been incredible. Dr. Kirkjohn has been incredible in partnering with us, with Whitman and with IT. It really has been a true partnership. So while we are in the process, the non-glamorous process of developing the infrastructure, we still must monitor and make sure that we're reaching our improvement targets for Qip and our other pay-for-performance programs, because again, that brings in sort of the financial support that allows us to do this larger work. And so this slide shows you one of our outcomes for our Qip program for our Medi-Cal patients. And so thanks to the work of Art Gomez, Whitman Director of Quality and Compliance, the Whitman Senior Leadership Team, and the Senior Operation Managers, the clinic managers, we really experienced significant improvement during 2021 for all of our Qip measures. And based on that, we do expect that we'll be able to draw down 100% of our funding allocation for 2021. So as I said earlier, we had 20 measures. We saw improvement in nearly every measure. We achieved or exceeded the target for 16 of the 20 quality goals that we had. We exceeded the target by more than 150% for 8 of the quality measures. And so this is just one example, breast cancer screening, but I can show you for the other 20 measures, we have similar trend charts. And I think our hope is to take this kind of really great improvement work and through developing this comprehensive quality strategy, really be able to show this type of data for all of our patients across all Whitman patients over time. That's really the goal that we're moving towards. And so that's the end of our presentation. We would be happy to answer any questions that you might have.
Any questions for them? No? Oh, thank you. Thank you. Thank both of you very much for your hard work, for the leadership that you're providing. And like you said, I'm sure it's a great team effort, and the trickle down to everybody who touches patients. It's all for their benefit. And we, as a Whitman patient, I thank you. Thank you for wanting to make things better, focused, efficient, doing a great work. Thank you so much.
Thank you.
Thank you. Have a good evening.
Thank you.
Okay, Mr. Henry, we have a finance report from you.
Okay. Thank you. Tonight, excuse me.
Need some water there?
Yeah.
Yeah. Sorry about that.
Debbie's drinking for you.
Thank you, Tina.
Thank you, Tina.
Okay, there, I think I got myself in order here. So tonight we will be looking at Washington Hospital's operating and financial results for April. And we'll start with our operating indicators. Inpatient average daily census for the month came in at 140.5. That's about 5.6% below the budget of 148.9. But when we fold in our outpatient observation equivalent days, we end up with a combined average daily census that is also below budget, but by about 3.8% at 149.7. Admissions for the month were 80 below budget at 764. Our patient days were below budget at 5,252 at 4,216. Outpatient observation equivalent days for April came in 76 higher than budget at 275. And our average length of stay was higher than budget by 0.7 at 5.99 days. Moving into utilization, case mix index for the month came in a little bit lower than budget at 1.627. Deliveries were 8 below budget at 106. Surgical cases, however, were 41 above budget at 373. Cath lab visits were 4 above budget at 200. We had 7,414 outpatient visits for the month. That was about 3% lower than the budget of 7,640. And our emergency room was about 10.2% higher than budget at 4,186 visits. We had expected 3,797. Quick look at the detail for the OR and the cath lab. Again, that 41 procedure variance in the surgery center or in the OR, really led by joints. We've seen this all year, and again, that's related to the expected shift of joint replacement cases out to the outpatient surgery center on the peninsula. Cath lab cases, again, 4 above budget. Peripheral vascular, cardiac, and non-vascular procedures really, or cases, all above budget by about 3 or 4 each, offset by neurointerventional radiology that was below budget by 4 for the month. Looking at productivity, productive FTEs for the month were 9.5 higher than budget at 1,318.1. Non-productive FTEs for the month were 199.1. We'd expected 156.9. And so we ended up with total FTEs about 51.7 higher than budget at 1,517.2. Our FTEs per AOB, which is our productivity measure, however, came in favorable at 6.12. We had expected in the budget about 6.68. So staffing was pretty tight. Moving into the financials, total patient revenue for the month came in almost $4.3 million higher than budget at $181,915,000. Our deductions from revenue came in higher than budget at 78.5%. Really was a payer mix issue. Medicare government payers were higher than we expected in the budget in the month, and PPO was lower. So we ended up with our contractuals for government and commercial sponsored patients higher than budget at 76.98% of gross revenue. But our in the payer mix, private pay was lower than budget, and we ended up with our provision for bad debt and charity also lower than budget at 1.52% of revenue for the month. So we ended up the month with net operating revenue that was actually about $572,000 lower than budget at $39,529,000. Operating expenses for the month were $311,000 higher than budget. We had a number of offsets going on here. Our salaries and wages were above budget about 4.5% or $858,000 with our higher FTEs. Benefits continued to be lower again this month. Health and welfare claims were $931,000 lower than budget. Supplies for the month were $283,000 higher than budget, and that was again pushed up by our prosthesis with our higher joint replacement cases. Professional fees for the month ended up about $390,000 higher than budget. Our physician fees for the month were $133,000 higher than budget, and then our consulting fees for clinical intelligence and Trifecta with their work around RevCycle were also higher than budget. Purchase services for the month, just $74,000 higher than budget, and it was really driven by recruitment. So we ended up the month, all in all, with, again, operating expenses higher than $311,000. We ended up with operating loss for the month at $1,166,000. Non-operating income for the month really showed a loss of almost $2.1 million, about a $1.6 million variance Again, we're seeing our unrealized losses on our investments as there's turmoil in the bond markets, driven by interest rates and other factors, inflation. But we did sustain an unrealized loss on our investments of $1.5 million in the month. So we ended April with, this is again the Government Accounting Standards Board presentation, with a net loss of almost $3.3 million. There we go. Taking a quick look at our Financial Accounting Standards Board, and this includes adjustments that the financial markets might make when they look at that GASB format. First thing they do is they reclassify our revenue bond interest expense out of non-operating and up into operating expenses. That's about $570,000 in April. So we end the month with operating expenses from a FASB perspective that were about $314,000 higher in budget at $41,265,000, and an operating loss of a little bit over $1.7 million. Next, they eliminate the things they don't recognize. That includes our general obligation bond interest expense and the related tax revenue out of our non-operating income. They also don't recognize that unrealized loss on our investments. So our non-operating loss for April from a FASB perspective comes in at about $261,000, and our total bottom line just under $2 million loss from a FASB perspective. Looking at our earnings before interest, taxes, depreciation, and amortization, first thing we do is we net out depreciation from our operating expenses because those are considered non-cash transactions. We end up with EBITDA for the month at almost $2.5 million. Then we go down and we look at our non-operating income and expenses before interest expense, and that showed a loss of $327,000 for the month. So all told, in April, Washington Hospital's operating and non-operating activities generated about $2.137 million in income for the purpose of paying our interest expenses and other capital and operational costs for the month. So are there any questions on April?
Nope.
Okay.
Very good. Thank you, Chris.
Mm-hmm.
Okay, our hospital operations report from Kimberly.
All right, thank you. I will be presenting May of 2022. All right, so starting with the gross revenue of $197.3 million for May was above budget by 14.6 million or 8%, and was above May of 2021 by 26.6 million or 15.6%. Inpatient gross revenue of $117.1 million was below budget by 4 million or 3.3%, but 17.5 million or 17.6% above May of 2021. Outpatient gross revenue of $80.2 million was above budget by 18.6 million or 30.2%, and 9.1 million or 12.8% above May of 2021. In May, we've had 47 COVID-19 discharges, representing 5% of total discharges. This was an increase from the prior month at 22 COVID-19 discharges and was 25 more than May of 2021 at 22 total discharges. And I know Dr. Hyder made mention that we have been seeing an increase in our COVID census to some degree. Moving on to key census statistics, average length of stay of 5.67 was above the budget of 5.08 by 0.59 or 11.6%, and above May of 2021 length of stay of 5.11 or by 0.56 or 11%. So the average length of stay for the 47 COVID-19 patients discharged in May was 11.7 days. There were 10 discharges with length of stay greater than 30 days, ranging from 31 to 309 And excluding these 10 discharges, our average length of stay would be 4.81. We do still have in-house, as I've mentioned in the past, we have 7 patients with long lengths of stay that are over 30 days, and they range from 31 days to 370 days. Our outpatient observation days at 294 were above budget of 211 by 83 days or 39.3%, but 18 days or 5.8% below May of 2021. Inpatient average daily census of 152.1 was above the budget of 143.9 by 8.2 or 5.7% and above May of 2021 average daily census of 130.4. Then lastly, combined average daily census of 161.6 was above the budget of 150.7 by 10.9 or 7.2% and 21.1 or up 15% above May of 2021. The combined average daily census includes both the outpatient includes our outpatient observation equivalent days. All right, moving on to admissions. Admissions of 856 were below budget of the 878 by 22 or 2.5%. May 2022 admissions were 112 or 15.1% above May of 2021. In May, only 8.7% or 15 cases of the total joint replacement cases were inpatient, compared to budgeted 38.9% or 58 cases, so a difference of 43 cases. So that those joints were impacting our admissions. Patient days trend, our patient days of 4,715 were above the budget by 253 or 5.7%, and were 673 or 16.7% above May of 2021. Although admissions were 22 or 2.5% below budget, patients stayed longer on average, resulting in higher patient days. So moving on to our surgical trend, we saw that total surgeries in May of 384 were above budget by 28 or 7.9%, and surgeries were 41 or 12% above May of 2021. Inpatient surgeries at 144 were 25 or 14.8% below budget, and 25 or 21% above May of 2021. Our outpatient surgeries at 240 were 53 or 28.3% above budget, and 16 or 7.1% above May of 2021. I know, as I've continued to say each month here, we had budgeted our outpatient joint cases were budgeted to begin migrating over to the Peninsula Surgery Center. I do want to say that we, on Thursday, April 28th, 2022, we completed our accreditation survey, and with no major issues by the survey that were identified. And so on May 31st, 2022, we had our first 4 surgeries done at the Peninsula Surgery Center. So we're very excited in terms of beginning to see patients there. Surgical activity, our joint replacement surgical cases were above budget by 24 or 16.1%, and were 30 or 21% above May of 2021. Neurosurgical cases were below budget by 8 or 26.7%, but were consistent with May of 2021. I do want to say we had 5 cases that were canceled due to COVID issues, so that also impacted our volume for May. Cardiac surgical cases were above budget by 8 and were 3 or 23.1% above May of 2021. All other surgical cases combined were above budget by 4 or 2.4% and 8 or 4.8% above May of 2021. Looking at our cath lab trend, cath lab cases for May at 196 were 7 or 3.4% below budget of 203, but 6 or 3.2% above May of 2021. Cath lab inpatient cases at 91 were 23 or 20.2% below budget and 2.2% below May of 2021. Our cath lab outpatient cases at 105 were 16 or 18% above budget and 8 or 8.2% above May of 2021. And to look at the how our cath lab activity is broken down, you can see that cardiac cases were below budget by 15 or 13.3%, and one case below May of 2021. Non-vascular interventional radiology cases were above budget by 11 or 23.9%, and 7 above May of 2021. Peripheral vascular cases were below budget by 4 or 10.3%, and 1 below May of 2021. And then neurointerventional radiology cases were above budget by 1 or 20%, and 1 above May of 2021. Deliveries, we did see an increase in our deliveries this month. So for May, there were 131 deliveries, which was above budget by 4, 3.1%, and 12 or 10.1% above May of 2021. Looking at our non-emergency room outpatient trend, our outpatient visits of 7,451 were below budget by 406 or 5.2%, and were slightly below May of 2021 by 13. In terms of what was primarily driving the volume, we had lab visits at 2,601, which were below budget by 14.6%, X-ray visits at 1,465 that were below budget by 17.7%. We're following up on both of these trends, but they were offset by our cardiac rehab visits that were above budget by 237 or 47.2% at 739. So with cardiac rehab, we're almost back to our pre-COVID volume, just a little bit under about 7%. Our outpatient wound visits have been busy. We've had 447, which were above budget by 98 or 28.1%, and 4.4% above the prior year. Moving on to our emergency room visits, they were 4,755, which were above the budget by 749 or 18.7%, and 24.7% above the prior year. Now looking at our gross revenue recap. Overall, our total gross revenue was 8% above budget. As broken down, you can see that emergency visits were above budget by 18.7%, driving emergency revenue up by $1.7 million or 16.1%. The mix of patient visits included more cases with lower complexity, which resulted in a little bit lower in terms of our increase in revenue. Patient days were above budget by 5.7%, and there were fewer ICU days. As a result, our room and board revenue was above budget by $1.7 million or 4.7%. Our surgical revenue grew $1.5 million or 4.2% as a result of higher than budgeted surgical cases. However, there were fewer neurosurgical cases than expected. Our deliveries were above budget by 3.1%, and there was an uptick in prenatal monitoring and stress testing, which were OB outpatient services that resulted in an increase in revenue of $461,000 or 13.5%. Cath lab revenue was below budget by 8.8% as a result of fewer than budgeted inpatient cath lab cases. Ancillary services were higher than budget by $10.4 million or 12.2% due to both an increase in inpatient and outpatient activity. All right, moving on to our preliminary payer mix. We still have some challenges with our payer mix, similar to what Chris had mentioned. Government-sponsored patient revenue made up 73.5% of total gross revenue. This is higher than the budget by 1.3% and higher than the prior year by 2.1%. HMO was 2.3% of gross revenue, which was below the budget of 2.7% and lower than prior year percentage of 4.1% of gross revenue. Also, our PPO was 21.7% of gross revenue, which was below the budget of 23.1% and lower than the prior year percentage of 23.4% of gross revenue. Lastly, our private pay was 2.5% of gross revenue, which was above the budget of 2% and higher than the prior year percentage of 1.1% of gross revenue. I do want to say that the increase in private pay is mainly driven by an increase of what we've been seeing in terms of out-of-country patients, and the charges for this month of May was approximately 2.2 million from out-of-country patients, which falls into our private pay bucket. Moving on to our productivity indicators. Productive FTEs were above budget by 96.6 or 7.4% at 1,394. Non-productive FTEs were above budget by 38.2 or 25.8% at 186.2. And total FTEs of 1,580.2 were above budget by 134.8 or 9.3%. Looking at our productivity metrics, our productive FTE per adjusted occupied bed of 5.44 was lower than the budget of 5.97 by 8.9% and lower than the prior year by 5.73, prior year of 5.73 by 5.1%. So much more productive than we were last year. Then total FTEs per adjusted occupied bed of 6.16 were lower than the budget of 6.66 by 7.5% and lower than the prior year of 6.4 by 3.8%. So very similar to last month. And then looking at our other primary outpatient statistics, Whitman clinic visits were below budget in May by 1,175 or 6.7% at 16,481. More than half of that, of those visits, basically we were down due to an open provider position, and that was in cardiology. Our new provider is now starting in June, and we had budgeted for that position to start earlier. And then we also had primary care visits that were lower due to some physician time off. Our Development Corporation outpatient visits of 2,202 were below budget by 102 or 4.4% for the month of May, but 2.5% above May of 2021 visits. As you can see, our Washington Outpatient Rehab Center was pretty much on budget, along with our outpatient surgery center that was just below budget by 4. Where we saw a decrease was Washington Outpatient Oncology Center treatments that was below budget by 59 or 15.9%. And I know we've talked about this in the past, that with the new linear accelerator, we've been seeing that there are new treatment protocols that have been put in place that have resulted in higher dosage of treatments that are requiring fewer visits per patient. So that's the main driver that we're seeing. We also, the machine was down for 2 days, that also had an impact on treatments. And then lastly, our Loney College Student Health Center was down by 38 visits, and the health center remains open, though many of the students are still taking classes virtually. All right, lastly, our key financial statistics, looking at our days cash on hand for May ended at 168 days, an increase of 5 days from last month due to basically higher cash collections in the month. Our days in accounts receivable as of May 31st were 64.3, an increase of 3 days from the prior month. Although we had strong collections in the month, our gross charges for the month were 15.4 million higher than the prior month, driving our AR days up. And then lastly, there were 312,000 in charity care adjustments in the month of May. So that is my report for May. We continue to be busy in many of the areas.
Good. Thank you, Kimberly. All right, announcements.
All right, I do have a couple of things. I want to start, of course, with our June Employee of the Month. It is my pleasure to introduce Benches Vergara, and she is our June Employee of the Month. And she works in our nursing staff office and can be, which she says can be like the game of chess, where you have to put the right pieces in the right places. She is very important to our staffing of our hospital. She has a background as a social worker. Benches joined the Washington Hospital family in February of 2018. But the healthcare system was already a part of her family because her husband, Paul, has been a technician at the Washington Outpatient Surgery Center for the past 16 years. According to her coworkers from day one, Benches showed kindness and professionalism with a positive attitude and a willingness to help other members of the staffing office. She admits that at times, particularly during high census, her role can be challenging. Benches sometimes has to rely on her persuasive personality to make sure the hospital has the right amount of staff in the right areas to be able to provide the very best care possible. Benches works the PM shift, which typically means she is the only staffing clerk on duty. Though the shift can be challenging, she knows that ultimately her work benefits our patients, and she finds that very rewarding. One of her staff office coworkers notes, "It takes a special person to be part of the staffing office team, and Benches is someone who exemplifies the calm demeanor and critical thinking that is essential to this job. She is well organized and is always willing to help others brainstorm for the next shift with any staffing shortages. Benches' spirit is always positive. She's a hard worker and is someone you can always trust and depend on as your colleague." So congratulations to our June Employee of the Month. Then I just have a few other announcements that I'd like to make. In terms of health promotions and outreach events, on May 6th, our athletic trainers from the Washington Sports Medicine Program volunteered to serve as medical coverage for a Special Olympics track event. The event was held at James Logan High School in Union City. Approximately 230 Special Olympic athletes from 15 schools participated, and they range from elementary to high school ages. On Thursday, May 12th, Dr. Seema Sehgal, psychiatrist, and Wahi Khan, social work, LMFT, gave on-site presentations at Ardenwood Elementary School for National Mental Health Awareness Month. Presentations were given to 10 classrooms of students in grades 1 through 6. On Thursday, May 12th at 6:30 p.m., Dr. Bhaskari Pila, a pediatrician, presented kindergarten readiness on Facebook Live and YouTube. 92 community members participated in the live event, and since then, 549 additional people accessed the presentation on one of our social media channels. On Wednesday, May 18th, Christy Caracappa, Health Insurance Information Service Coordinator, presented information on advanced healthcare directives and physician orders for life-sustaining treatment to the residents of Acacia Creek Retirement Community in Union City. 30 residents attended. And then on Thursday, May 19th, from 6 to 7:30 p.m., Washington Hospital hosted the Celebration of Life. The event sponsored stories of survival and hope for cancer survivors and their families. 50 community members were in attendance. The Washington Hospital's Green Team promoted Bike to Wherever Day on May 20th and encouraged biking to work that day, and the Green Team hosted an Energizer station at Fremont BART, offering water, fruit, pastries, and other goodies. Yes, it was a good event. Critical Care Celebration Month was celebrated in May with the theme of diversity, equity, and inclusion. Activities included a multidisciplinary grand round on May 20th with presentation on COVID, past, present, and future from Dr. Monica Gandhi, and approximately 185 individuals attended the event on Zoom. There was also a celebration on May 31st, and about 70 staff members from all different teams throughout the hospital attended the event. We also held on Saturday, June 4th, our tattoo removal clinic in partnership with Second Chance, a Newark-based counseling and recovery agency. The tattoo removal program is designed to help teenagers and young adults make positive changes in their lives by removing symbols of past negative behaviors and actions associated with gang and drug activities. 27 individuals attended. As of May 31st, a total of 89,231 COVID vaccine doses have been administered to community members at our vaccination clinic. So we're continuing to do that. And then upcoming events on Thursday, June 9th at 6:30 p.m., Dr. Tam Nguyen, Family Medicine will present Men Take Charge of Your Health on Facebook Live and YouTube. And then on Wednesday, June 29th, Maria Noonan, Clinical Manager of the Stroke Program, will present information on stroke awareness to the residents of Acacia Creek Retirement Community in Union City, similar to what Dr. Rose presented to the board this evening. And then in terms of our foundation, I do want to announce that our Washington Hospital Healthcare Foundation's 35th annual golf tournament took place on Thursday, May 5th at the Club of Castlewood. After expenses, the tournament raised over $68,000 for surgical services. So that is my report for this evening, or the announcements.
Good. Very good. Thank you. Well, we will now go into closed session. However, before doing so, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session. As we do not know how long the closed session will last, we do not want members of the public waiting indefinitely on the phone for the board's report. Therefore, we ask that you contact the district clerk tomorrow, and she'll be happy to respond to any inquiries about reportable board actions. Our minutes will continue to reflect any reportable actions taken. Thank you. The board will now adjourn to closed session. Thank you, everyone.